as people can see as they're joining, we have a speaker who just, everyone should be the speaker. Such dedication to say, I'm going to still persevere despite having to wear a cervical collar. But I just want to give Dr. Richard Garfein an introduction, because I think it's been a couple of years since he's spoken. We have new high rounds attendees. He's well known to a lot of us, but I did just want to give a brief introduction, and then I will hand it over to Richard. Dr. Garfein is an infectious disease epidemiologist, educator, and healthcare innovator who seeks to understand the causes of disease and translate that understanding into impactful solutions. He got his PhD at Johns Hopkins University and MPH at San Diego State University. He served as an epidemic intelligence service officer and epidemiologist for 7 years at the CDC before joining UCSD School of Medicine faculty in 2005. His research primarily focuses on airborne and bloodborne infections, often associated with health disparities and substance use, including TB, HIV, and viral hepatitis, both in the US and abroad. His research on digital adherence technology over the last decade informed CDC and WHO guidelines on the use of telehealth for remotely monitoring patients with TB. With that, I am going to hand it over to our esteemed Dr. Richard Garfein. If you'd like to share your story, you may. If not, you may go. And obviously, if you need a break, just let us know. And I'll be monitoring the chat. Yes, you already have a tell us what happened, as people want to know.
All right, fine. Well, I'll tell you one thing. It wasn't because I was out on those gigantic waves at Black's Beach this week. Instead, it was on one of the off days when it was a little smaller and I was surfing too close to shore and I went headfirst into the sand in about waist deep water. So my advice is stay on the outside with the big waves. Don't mess around in the shallow water. That's the dangerous place. Anyway, my spine will heal. And fortunately, I have all my capacities, at least that I can tell of right now. And so this is a good test for me to make sure I'm actually still fully functional. So thank you very much for the opportunity to present. It has been a couple of years. I've been working on this research for about a decade now. Actually, it has been a decade. And there's a lot of people who've been involved in it. And I'm just excited to have the opportunity to share what we've done over the past decade and hoping that we can find some opportunities to collaborate and continue this work. So what I'm going to be talking about is video directly observed therapy, or VDOT, for monitoring treatment adherence for TB, LTB, latent TB infection, and beyond. And I do have a disclosure. Through this work, we founded a company that provides video dot service because the health departments that were in our studies wanted to continue using the app after it was over, and this was the best way that we could figure out how to do that. However, no funding, software, or other resources have been provided for any of these presentations. In order to mitigate any conflicts of interest, all the interpretations and reporting of our study findings were approved by co-authors who are unaffiliated with the company. And this arrangement has been approved by UCSD's Office of Conflict of Interest. So first of all, the issue of medication non-adherence is not unique to TB. It's a huge problem. Annually in the United States, it's estimated that medication non-adherence costs our healthcare system between $100 and $290 billion. The non-adherence leads to poor health outcomes. And in the case of antimicrobial resistance, poor adherence is a big contributor to that development of resistance. So speaking of tuberculosis, when we're talking about treatment of TB, it's a bacterial infection and it's very difficult to treat because the bacteria doesn't replicate very quickly. And so it requires treating the patient with antibiotics for typically 6 months. There's new treatments that are coming on the market that are intended to shorten that treatment, but still will require several months. But in the typical case of garden variety TB without any drug resistance, that's treated in 2 phases. The initial phase takes about 8 weeks with 4 different antibiotics, and then another 18 weeks with two drugs And overall, that ends up being about 1,000 pills the patient has to take over a 6-month period. And these pills are not, they're not without side effects. Some are toxic to the liver, and others just cause nasty rashes and itching and gastrointestinal problems, which obviously is going to make it difficult to motivate the patients to take their medications. And the WHO estimates that 30 to 50% of TB patients fail to take their medication doses as prescribed. And the problem with this is that it leads to, with TB, recurrence of disease. And on the panel on the left-hand side, these are data from a meta-analysis from 3 different TB drug trials, which show that when patients take their medication at less than 90% adherence, the risk of TB reoccurring after treatment is 5.6 times higher. And on the right-hand side, you can see some additional data from another study showing that as adherence gets worse, the rate of recurrence of TB at an 18-month time point also increases dramatically. In addition, other studies such as this one here indicate that the risk of development of de novo drug resistance increases as adherence decreases. And in this modeling study, it shows that the risk of generating multi-drug resistant TB, that's TB that's resistant to the 2 primary drugs that we use to treat the disease, it's highest between 40 to 80% adherence. And the authors conclude here that probably the cheapest and most effective way to ensure a positive treatment outcome while minimizing the risk for emergence of MDR-TB is to maintain proper patient compliance with treatment. So for these reasons, we monitor adherence to TB treatment. And the purpose of monitoring is to document that all doses were taken. And this is important because with bacterial infections like this, we don't actually have a way of knowing when every single bacteria in a person's body is dead. So the idea is that they are treated for a certain amount of time, which through over history, we've observed that when patients are treated for a certain amount of time with a certain number of pills, the likelihood of the disease coming back is extremely low. And so the importance is to make sure that the patients have actually taken that full dose of treatment, because we really don't have any way other than watching for recurrence to know if the patient is fully treated and cured of the disease. Also, medication adherence monitoring helps to promote treatment completion, and it's important because it is useful in detecting adverse drug effects that might require changing of the treatment regimens. And the goals of medication adherence monitoring are to reduce TB morbidity and mortality, to prevent ongoing transmission of the infection, and to avoid generating new drug-resistant strains. So the method that's recommended for monitoring treatment by the CDC and the WHO, and it has been for several decades now, is what's called directly observed therapy, or DOT. And this is a method in which a health worker or trusted agent is assigned to watch patients swallow their medications for every dose. And this could either be done in the patient's home, and we refer to that as community-based DOT, or the patient could be asked to return to the clinic every day to take their medication, and we refer to that as clinic-based DOT. And the rationale for this is because it's been shown to improve adherence. It reduces the risk of acquired drug resistance, treatment failure, and treatment relapse, or excuse me, disease relapse. And it establishes rapport. It helps to establish the rapport with the patients to encourage them to continue with their medication. And in some cases, it allows intermittent dosing, because if patients are taking their medications consistently, then sometimes the spacing between doses can be increased for their convenience. But as you can imagine, there's a lot of barriers to doing directly observed therapy. Obviously, it costs money either to the patient or the provider in terms of their time and travel. In addition, it requires personnel, which are often limited in low resource healthcare settings, and it requires travel either for the patient or the provider. In addition, it can increase the likelihood of stigma or breaches of privacy for the patient if they're having to go to a TB clinic every day, or if a health worker is showing up at their house every day to watch them take their medications. People might wonder what's going on. And in many parts of the world, TB is highly stigmatized and can really affect people's status in their communities. And just the fact of having to be watched taking your medication affects people's ability to move about and also to do their activities of daily living, and which really affects their autonomy. But very importantly, now we have COVID-19, which has really put a damper on the ability to do DOT in person. And just to give you some idea of that impact, this report by the Stop TB Partnership focused on 3 high burden settings in India, Kenya, and Ukraine. And they report that TB notifications, that is identifying new cases of TB in January to May of 2020, decreased dramatically compared to the same period in 2019 and in 2015. Also, TB treatment completion rates were reduced from 60% in 2019 down to 51% for the same period in 2020. And screening for TB drug resistance has also declined significantly during 2020. And these images on the right are from a modeling study where the blue line is sort of where we were in terms of progress towards TB elimination. And the yellow lines are where we think the incidence of infection and mortality will be given the impact of COVID-19. And that's with 3-month lockdowns and or 2-month lockdowns and 2-month restoration efforts. And even with more rigorous restoration and prevention measures, the red line shows that we're still not going to get down to baseline. And so this impact of COVID on TB elimination is real. Another way that that COVID-19 has impacted TB is that it disrupted transportation and limiting health facilities to providing only emergency services impairs access to TB diagnosis and treatment services. And TB treatment disruptions have been reported by nearly 80% of the global fund-supported TB programs around the world. 17% of these programs reported very high rates of disruption. And furthermore, modeling studies predict that an additional 6.3 million cases of TB and 1.4 million deaths over the next 5 years will be due to these disruptions. And TB control will be set back by 5 to 8 years, receding even further away from our 2030 target of TB elimination. So COVID has definitely had an impact on TB. So how can we get around this problem? If the goal is to make sure that patients are taking their medications, and DOT has been a highly effective method of assisting patients in taking their medication and getting them through treatment, what other technologies can be used to try to facilitate this and get around the problems of face-to-face contact with the patient? And there's a number of technologies that have been developed over the last decade or so, and these all can play a role. The way I like to describe them is that they fall into basically 2 categories. One is what I refer to as pill in hand technology. And these are things like electronic pill dispensers. Many people who have been involved with therapeutic drug trials are familiar with MEMS caps. They were very widely used in the early days of HIV drug trials. And these are pill caps that sense every time a pill bottle is open, and it counts up how many times the pill bottle is open and records the date and time. Now they've gotten more sophisticated where they're actually connected by Bluetooth to phones, and that information can be sent to a database, and a healthcare provider can see that information remotely. More recently, there's been pill boxes that can actually do the same thing, where every time you open the pill box, it will detect that it's been opened and count that that the pills have been taken out. There's also technology that was developed by Microsoft Research, such as 99 dots, which is it's a blister pack that contains unique codes underneath the tab. And so every time a patient pops a pill out of a blister pack, they see the code and then they send a text message to a certain number with that code, and then it documents that the patient is taking that pill. And there's also SMS text messaging interventions that do similar things. The reason I call these pill in hand technologies, though, are that patients are it documents that the patient took the pills out of the pill package, but it doesn't tell you whether or not they actually put it in their mouth. So other technologies that are available are what I call pill and mouth technologies. And these have been around for a long time when we look at things like metabolic testing of human samples such as urine, blood, or even hair that can look for the presence of metabolites of the drugs that the patients are taking. These can be complicated, and there's issues of patients if they don't take their pills regularly and then they do take them right before their visit, the drugs might show up even though they haven't been consistent with their treatment. And then there's other technologies such as the ingestible sensors that Dr. Sarah Brown has talked about in previous high rounds. And this is a microchip that's embedded in a pill that sends off a weak signal when the patient swallows the pill, and it interacts with acid in their stomach. And the signal is read by a patch that they wear on their side. And then that patch is connected by Bluetooth to a phone or a computer and records the signal that the patient actually swallowed the pill. And the last technology that I'm going to talk about today is video-directed observed therapy, which is also what I call pill and mouth technology.
Richard, you're muted.
Come back. There I am.
Hey.
Thank you. Video-directed observed therapy, or VDOT, comes in two flavors. There's synchronous video dot, which is what a lot of our healthcare providers are doing lately with live video conferencing with patients. Sometimes we refer to this as real-time or live VDOT. And then there's asynchronous video dot, which involves recorded videos, sometimes referred to as store and forward. So first, I'll talk briefly about synchronous video dot. With synchronous video dot, the process looks like this. The healthcare provider schedules an appointment with the patient. At the time of that appointment, both the patient and the provider get online, either through a phone or a computer, and they have a live video conference. And during that conference, the patient shows themselves taking their medication, and so the provider can observe it. And then the provider documents what they see into the patient's medical record. And there's been several studies that have looked at this, and they've actually documented that synchronous video dot produces high adherence and high treatment completion rates. In many cases, even better than in-person DOT. Also, there's been high patient and provider satisfaction with this method, and it's been documented to save resources in terms of travel and patient and provider time. The limitations of synchronous video dot, though, are that it's still restricted to business hours because the provider and the patient have to be online at the same time. So it makes it difficult to do monitoring on weekends and holidays and evening hours. Also, just the process of scheduling the appointment for the video dot visit takes time from staff, and that affects costs. Also, dosing times are not always acceptable to the patients. We've learned that because these drugs cause patients to have side effects such as upset stomachs, they often like to take them with an evening meal and potentially, and oftentimes before going to bed so that they can sleep through any side effects. And this is difficult when you're requiring patients to take their medications during business hours. It also requires reliable connectivity, and not all video conferencing apps meet security standards for personal health information, and so they don't always meet HIPAA or GDPR requirements. So that's what, so based on the experience that had already existed before I got into this area with synchronous video dot, the question came up, well, could this be done with mobile phones, and can it be done in such a way that we can avoid some of the other problems with synchronous video dot? And so we came up with this idea of having an app on a phone that a patient can use to open up the camera on their phone, which would allow them to make a selfie video of the medication ingestion process. And then that video can be sent to a secure server where a healthcare worker can watch that video asynchronously, observe what the patient did, and then if they took all their medications, document that in the patient's record. And once that's been done, that information can be put into nice dashboards such as this, where the provider and the dot worker and their patient supporters and anybody else who would need this information could access it and see what doses the patient has taken and when they're missing doses. And most importantly, when doses are being missed, somebody can respond appropriately to help that patient get back on track with their treatment. And so part of this came from an idea that we got from a study that was conducted in Kenya. This is the first video dot study, asynchronous video dot study that is in the literature. And this study was done in Kenya that included 13 patients with 3 healthcare providers. And what they would do is a patient treatment supporter, usually a family member, would use a smartphone to make a video of the patients taking their medication. And also the patients can receive educational text messages and video messages using the phone. And they were followed for 30 days. And so this was just a very crude pilot trial just to see if this would work. And the results came out that the patients, providers, and the supporters agreed the video dot was a viable option. 62% of the patients actually preferred video dot over the in-person dot they had previously been receiving. And patients and providers reported being empowered by the ability to communicate with each other through this technology. So given that our county health department at the time was using asynchronous video dot with old school dial-up phones with the camera on it that were plugged into the wall, and but we're having a lot of success with that. We said, well, how can we make this mobile, and can we make it work better than the old technology? And so we applied, and on our first attempt got funding through the NIH with an R21 grant. And the objective of our study was to assess the feasibility, acceptability, and potential efficacy of video dot for monitoring TB treatment. Pretty simple idea. But we didn't have any technology yet, so we had to build it. And we built that here at UCSD with the support of the Qualcomm Institute and faculty such as Kevin Patrick, who was instrumental in helping out with that. And we built the technology, and we gave it to the San Diego County Health Department TB program and the TB program in Tijuana, because we said, if this technology works, we want to know if it's going to work not only in a high resource setting such as San Diego, but also a low resource setting such as Mexico. And that's the convenience of living on the border, is that we can do these kinds of studies very easily. And we gave the technology to the TB control program staff. We said, you use it with your patients and let us know how it works. So we wanted to really see how this worked in a real world setting. So we started out with focus groups with patients, providers, and health officials in both cities to really understand what the needs were and whether or not this would be acceptable and how to build this technology. And then once we had the technology, we conducted a single arm pilot trial, which included patients who are 18 years of age or older. We weren't sure how well this was going to work, so we only had patients with pan-sensitive pulmonary TB, and they had to have already been using directly observed therapy in person for a period of time before we got started, because we wanted to be able to compare how patients and providers view the two different methodologies. And so we conducted interviews with patients before and after they started using VideoDot, so we can get a sense of what they thought of it. And here are the baseline data. We ended up with 43 patients enrolled in San Diego and 9 patients enrolled in Tijuana. We actually had 6 patients who were binational, and so they actually spent time on both sides of the border, which is a very difficult patient population for our county health department to treat because patients aren't always here. The age was impressively up to age 86. We had concerns that people who are older would not be able to use this technology, and the health department was sort of encouraging us to only include young people, assuming that those were the ones that would be able to use technology. And we had a good mix of race and ethnicity. About half were female. We did have a few patients who had to switch back to in-person DOT after a period of time. 3 of them were per protocol because it turned out that they had drug resistance and they shouldn't have been enrolled in the first place. And the other 4 had some difficulty with the technology, and the health department decided to put them back on in-person DOT. We also gave all the patients phones because we wanted to control that variable in our study. And we did lose a few, but it was about 13%. So it turns out you can actually give patients a smartphone and get it back in most cases. And so here are the results of the trial. The figure on the top shows the adherence rate for patients in the trial, and the majority had greater than 90% adherence. We had a few that were between 80 and 90%, and a couple of patients that were less than that. And these were probably the patients that had to switch back to in-person DOT. But overall, the adherence in San Diego was 93%, and in Tijuana it was 96%. We also asked on the follow-up interview about their experience, and over 85% of the patients in both cities said that they never or rarely had problems making videos. Most of the patients preferred VideoDot over DOT if they would have to repeat their treatment. 100% in both cities would recommend VideoDot to other TB patients. And most of the patients also said that they found that VideoDot was more confidential than in-person DOT. It was something that they had more control over, and they can take their medications without anybody else seeing them or asking questions about their treatment. So we're really happy with those results, and we talked to some people at the Verizon Foundation and found out that they really like this idea as well. I guess they thought they could sell more airtime and more phones with technology such as this. So they gave us a grant to expand this study to see if we can get the same results if we try it in other cities. So we conducted a similar trial that included 3 different high burden cities in the United States. That included San Francisco, San Diego, and New York City. And again, we implemented this by giving the technology to the TB program staff and let them monitor their own patients. This is, again, a very similar single-arm pilot trial. It included patients that were 18 and over, but in this case, we didn't exclude patients that had drug-resistant TB because their treatment is essentially the same, and there's some benefit to allowing them to use DOT as well. The patients were followed for a minimum of 2 months, and we also conducted pre and post treatment interviews to gather information about patients' satisfaction with their treatment. So here in this top row, you can see what we call the FIDO, or the fraction of expected doses observed. And you'll hear me refer to this throughout the talk. It's difficult to talk about adherence because adherence means did they take all of their prescribed doses? And I showed you before that patients need to take a certain number of doses in order to be considered completed treatment. Now, normally in the course of treatment monitoring, if a patient misses a dose that was expected, they just add that dose on to the end, and the patient continues taking treatment until they finish all of their doses. But that's a difficult measure to use when we're looking at some technology like this, and we're looking at short periods of time of treatment rather than the whole duration of treatment. So what we calculated is this fraction where we have doses that are expected. So every day that a dose was supposed to be taken, that becomes the denominator. And the numerator is the number of doses that were actually taken on the day that it was scheduled. So if a patient misses a dose and a dose gets added to the end, the denominator gets larger and the fraction of expected doses observed gets smaller. So that's our measure that we're using. And in all three cities, the fraction of expected doses observed was 85% or higher. And there really wasn't any difference between the cities. And these patients in the study had all been observed on using VideoDot for a median of 5 months. So very high adherence or FIDO, and also similar across the three cities, which we're happy to see. And so on the follow-up, we asked participants about their experience, and very few reported that they ever had a problem recording their videos because they were concerned about other people seeing them taking their medication. Also, we asked again about confidentiality of VideoDot versus DOT, and the majority of patients again said that they thought that VideoDot was more confidential or at least no difference. Very few thought it was less confidential. And the people who did reported that they just weren't sure who was watching their videos. And we were able to explain to them about the security features of the process, and that helped them to feel more secure. And then overall, how did you find the VideoDot process? The majority, again, said that it was either very easy or somewhat easy. And then when asked if they would choose VideoDot over DOT for their treatment, nearly all of them, again, said that they would use VideoDot, and most of them would recommend VideoDot to other patients. So we found very, very similar results across the three cities that we found in our original study. So then the question came up, would this work similarly in rural areas where patients are living farther from health centers and might have less connectivity to the internet or through either cellular or Wi-Fi, and would this be a problem? Plus, people that live in rural areas are very difficult to monitor with in-person DOT. And so we received a grant from the California Healthcare Foundation to look at this. And so we were looking at the feasibility, acceptability, and potential efficacy again, this time in 5 counties in California. And so our urban counties are considered San Diego, San Francisco, and Santa Clara. And our 2 rural counties were San Joaquin and Imperial County, where also TB rates are very high in California. This time we included a comparison group. So in addition to the 174 patients that were prospectively enrolled in a VDOT trial and monitored for treatment, we also looked back at medical records for a random sample of 159 patients who had completed TB treatment using directly observed therapy to look at what their adherence was. And so the eligibility here again was age 18 years and older. Patients could have drug sensitive or drug resistant TB. We looked at a 6-month follow-up period, and we interviewed patients before and after treatment. So in this case, we looked at the FIDO, or the quasi-adherence, and you can see across the second row down here that the adherence again was over 80% in all 5 cities. And when we look at that comparison, there is some difference across the cities. The p-value is less than 0.001 across the 5 cities. But when we compared the 2 rural counties to the 3 urban counties, there was no difference in adherence by that factor. So then we looked at the FIDO for the patients that were monitored with DOT. And so the red bar are patients that were on VideoDot. They had a median FIDO of 93%, and then compared to the FIDO among the patients that were received in-person DOT, their FIDO was 66%. And so the adherence was higher among patients with on VideoDot. However, if you look at overall adherence, and by adherence I mean did they actually take the number of doses that they were supposed to take, our TB programs in California are extremely good at getting patients to take their medications. So on average, they took 100% of their doses, and that often took not the normal 6 months, but could extend out to 9 months or longer just to get those patients to get every last dose in. And so the take-home message there is that video dot can get the same results as in-person dot, but with less time and less effort by the health departments. And so when we looked at, one of the other questions that we had was, are there any factors that you could look at for a patient before they start treatment that would indicate who would have higher adherence and who would have lower adherence? And the reason for this was because health departments were trying to decide, should there be some criteria for which some patients would be put on video dot and other patients should be kept on in-person DOT. And so considerations were things like age, access, previously owning a cell phone, whether or not they live in a rural area that has good Wi-Fi, a number of different socio-demographic factors, income, et cetera. And we put all these into models and we tried to figure out if there were any that predicted the adherence rate. And we found that if you're born in Asia, mostly, compared to being born in Mexico or the United States, you would have a higher adherence. I'm not sure why that is, but that was observed. Also, if patients were having difficulty using the technology, then they had a lower FIDO, and you can see that by these negative beta coefficients. Also, if the patient took most of their medications while they were away from home, such as traveling or taking their medications while they're at work, that also lowered their adherence a bit. And then if they had problems using the application, that also lowered their adherence. But the key, though, is that these are all things that occurred during treatment, except for place of birth. But there were no specific patient factors that could be used to decide this patient should get video dot, this patient should get DOT. So the key message from that was that health departments can offer video dot to all patients and then just monitor them, and the ones that seem to be having difficulty with it can be put back onto in-person DOT, as opposed to trying to restrict it a priori. And then just to show some other results from studies besides our own, this study was done by Sam Holtzman and colleagues at Johns Hopkins University in Baltimore, and they conducted a pragmatic prospective pilot study in 3 TB clinics in Baltimore. The design was very similar to the trials that I've just described, and they also found a very high adherence, and in this case, adherence is referring to taking the number of doses that they needed to take, and then they refer to the observable fraction, which is what we refer to as the FIDO, and again found high rates of observing the medications being taken, and they did notice a difference between in-person DOT and video dot, where video dot had a higher observation rate than in-person DOT. And that makes sense because patients that have to be seen in person oftentimes are more likely to miss a dose. So what about outside the United States? The first study that I know of that was done outside the US with video dot, other than that initial Kenya study, was by Dr. Fatima Munoz, who received a CFAR developmental grant. And her objectives were to evaluate video dot for monitoring TB treatment adherence among HIV TB co-infected persons in Tijuana. And with her methods, she recruited patients who are on oral TB medications from Capacites, which is the AIDS treatment program in Baja California, and from Tijuana General Hospital. Patients had to be 18 or older, had to be able to speak Spanish, and had no plans to move from Tijuana within the study period. She also did pre and post treatment interviews to assess satisfaction and patient characteristics, and then also reviewed medical records from a sample of 50 patients who had only used DOT to look at their adherence. And so here on the left are the patients that were recruited and used video dot. There were 19 of them. And on the right are the patients that we reviewed medical records to see what their adherence was. And 2 points just to note here is that in the group that used VideoDot, there were only 2 or 9.5% of the patients abandoned treatment. They were lost to follow-up, whereas in the in-person DOT arm, 12 patients or 28% were lost to follow-up. And when they looked at the fraction of expected doses observed, it was similar and high in both. So it looks like this works for HIV positive patients in Mexico. And then just for sort of the sake of time, this slide here just shows similar data to the other studies from the US, showing that patients were highly satisfied, had little difficulty using the technology, and thought that the technology was more confidential than in-person DOT. So where else has this been used? Subsequently, a study was conducted in Vietnam. This is also a prospective cohort study with a single arm. They enrolled 40 patients. This study included patients as young as 15 years old with drug-susceptible TB, and those patients had to have at least 2 months remaining on treatment to be enrolled in the study. And what they found was, again, the median fraction of expected doses observed was 88.4% with a range of 75 to 94%. Overall, 71% of their patients completed all doses. 88% of the participants said that they would recommend VideoDot to other TB patients. And both the participants and the providers rated VideoDot highly, despite having some initial difficulties with the technology. Another study was conducted in Kampala, Uganda. And again, here, I'm looking at feasibility and acceptability of VideoDot for monitoring patients on TB treatment. The study was conducted in Kampala, Uganda. It was a prospective cohort study that included patients between 18 and 65 years old with greater than 3 months of treatment remaining, and again, only including patients with drug-susceptible TB. Some of these studies were tended to err on the side of conservatism because, especially in a place like this, they were concerned about how the technology would work and whether or not cellular or Wi-Fi signals would be available to actually transmit the videos. And so these patients were followed for an average of 3 months, and pre and post treatment interviews were conducted. Here's some interesting statistics from the study. Patients were monitored on for a mean of 103 days. Overall, they were expecting 5,150 videos in this short little pilot study, and they received 4,231, or 82% of the videos that they were expecting they did receive from patients. So it looks like the technology is working and patients were able to send videos. And then importantly, the fraction of expected doses observed was over 85%. And this is important because, as I showed you earlier, treatment really needs to be above 80% to ensure that we're not generating drug resistance and patients are effectively being cured of the disease. Dr. Sekendi had also looked at whether or not the adherence or FIDO was affected by gender, and there was no difference between men and women. There was also no difference by age groups. They were wondering whether or not prior cell phone ownership might affect people's ability to use VideoDot, and there was no difference there. But there was some difference between in adherence based on how long people were in treatment. And this is sort of just a reflection of some patients who are having difficulty with the technology or just poorly adherent in general would have dropped out of treatment earlier, and so their adherence would be bad if they had, or they would have had shorter duration of treatment if they had poor adherence. Again, similar questions were asked about satisfaction, and as you can just sort of quickly glance here on the right, satisfaction and recommending VideoDot to others was very high in all these categories. One thing that was interesting to see also is that they looked at how far away people live from the clinics. So the H's here in the middle are where the TB clinics are, and all these flags indicate where patients live. And so you can imagine it if healthcare providers had to drive out to patients' homes or vice versa for DOT on a daily basis, it would be usually impossible for some patients. So with Video Dot, they were actually able to get monitoring for these patients that live far away. One other thing that was sort of interesting from this study is they created a placemat for the patient where they can put their pills on the green and blue dots so that they know what pills they're taking, and they put a space for the glass of water, and then they have instructions for what they should do in their videos, and also a list of side effects that they wanted the patients to report if they were experiencing them on the videos. So a nice handy tool that this group came up with. Just as a really unique situation where Video Dot was used was in Haiti. Health Through Walls, an organization that works with prisons around the world, received a grant from the Stop TB Partnership, and they were faced with a particular challenge where in Haiti, overcrowding in correctional facilities creates an environment that's ripe for TB transmission, and a third of the prisons in TB actually lack a full-time health staff member. Which means that TB care is not provided in those prisons. So if somebody has TB in a prison like that, they don't get treatment because they can't be observed taking their medications. So there's a lot of barriers to treatment for TB in these prisons. And then in 2019, the increase in civil unrest prevented movement of citizens, including prison officers and staff, to get to work or medical clinics, and prisons often remain locked down. So opportunities for treating TB in prisons in Haiti was just a real mess. And so they, Health Through Walls got a grant, and they used Video Dot in 5 prisons with no history of providing TB treatment. These are prisons that don't have a on-site health officer. And they compared that to DOT in 3 control prisons where they do have health officers. And what they did was they gave the correctional officers a tablet computer with an app on it to be able to conduct Video Dot, and they would record each patient taking their medications every day, and that video would be sent to a central location where health workers can watch the videos and document their adherence. And in the event that the technology didn't work or something happened, the correctional officer would document whether or not they saw the patient took their medication. And so as a result, they ended up enrolling 67 patients who are successfully able to use Video Dot in all the 5 sites. They had a median adherence using Video Dot alone of 85.7%. And when they included the correctional officer's observation for the doses that were missed, they actually said that 100% of the doses had been taken. So the challenges from this site were obviously the civil unrest causing complete lockdowns and maintaining continuous network connection. These were problems. But in conclusion, they found that Video Dot continued inside the prisons despite unrest, and patients continued to receive their TB medications. Video Dot, facilitated by correctional officers, allowed provision of TB treatment in these low resource correctional settings, and Video Dot enabled continuous patient monitoring, treatment, and follow-up. So that's a few of the studies that have been conducted globally, and as you can see on this slide, there's many other evaluations ongoing. But all of these, and because of that, these studies, the WHO in 2017 updated their guidelines for TB treatment and included a recommendation that Video Dot could be used as a replacement to DOT. However, all the studies that have been done up to that point were observational studies, and WHO actually made a conditional recommendation because there weren't any randomized controlled trials until 2019, when a group in London published the first randomized controlled trial where they compared patients randomly assigned to receive in-person DOT or directly observed therapy. And this study included TB patients age 16 and older who were eligible for DOT at participating clinics, and it excluded anybody who didn't have the ability to charge a phone or was going to be moving or had less than 2 months of treatment left. And what they're looking at as their outcome was the proportion of patients who had taken at least 80% of their doses. and by observation. And so they collected data pre and post treatment, they looked at adherence records, and they also looked at the cost. So on the left-hand side is the flow diagram from their study. They assessed 548 patients for eligibility. They randomized 226 equally into the two arms, and then they followed them for treatment outcomes. And on the top figure on the right, the blue bars are patients that use video dot, and the red bars are patients that use DOT. And this is the proportion of patients who had completed at least 80% of their doses by observation. And as you can see, there's clearly a big difference between the two arms. However, what happened was when they enrolled participants in the study, within the first week, half of the patients that were assigned to the DOT arm stopped taking treatment. They just they couldn't handle coming in for DOT on a daily basis. However, nearly all of the patients who were assigned to the video dot arm completed. And so they did a per protocol analysis, excluding those patients that dropped out in the first week. And so the bottom panel on the right shows those data. And so you can see that the proportion that actually completed at least 80% of their doses among the patients on DOT increased for those that actually did go through DOT, but there's still a statistically significant difference between the two arms. And this graphic I like, it's sort of interesting. It shows every line is a patient's treatment adherence record, and every black dot is a dose observed, and every gray dot is a dose not observed. And so you can see for the patients on DOT up above, there are a lot of missed doses, and it's not just in the beginning or the end, it's actually dispersed throughout their treatment, and many patients never actually got observed taking any doses. Whereas on the bottom, you can see for video dot, the proportion of doses that are actually being observed is much, much higher. And just as a point, this population that was recruited was not an easy population to begin with. The majority had some social risks, such as homelessness, incarceration, history, drug abuse, alcohol abuse, mental illness, and immigration concerns. So it was really a challenging population. And then I know I'm running out of time, so I'm just going to speed through this. A second randomized controlled trial was done. This was a interesting design. It was a crossover design where patients were randomly assigned to receive either in-person DOT or what they're calling EDOT, which is actually video dot in New York City. And then once they took 20 doses, they were crossed over to switch to the other modality. And then after they took another 20 doses, they could choose whatever treatment course they preferred. And then what they were looking for was whether or not video dot was non-inferior to in-person DOT. And this graphic here shows you that whether they looked at the intention to treat analysis or per protocol analysis, they showed that in all cases, video dot was non-inferior to in-person DOT, which is important for New York City because they have the highest rates of TB in the country, and for just providing DOT is a very, very costly part of their program. So in conclusion from that study, they found that among 173 participants, treatment adherence on video dot was non-inferior to DOT, with 1.8 to 4.1% more doses being observed when video dot was used. And after the trial, 84% of the participants who were, whichever arm they were in, they chose to go back to video dot for the remainder of their treatment, indicating high acceptance. So this last study I just want to mention is a study where we actually tried video dot for latent TB infection. When this study was funded by the NIH, at the time, there was a new treatment out for TB that involved using the drugs isoniazid and rifapentine, and it can be given in 12 doses given 1 week apart for 3 months, and so it was named 3HP. And this was in comparison to the traditional treatments of isoniazid given daily for 9 months or rifampin given daily for 4 months, and both of these regimens are self-administered. But the nice thing about the 3HP regimen is that it's only 12 doses and it can be finished in 3 months. The problem was that the CDC recommended only using this if DOT was the method of delivery, because if they miss a dose, they're missing, basically 2 weeks of time. And so we decided to use that population and randomly assign participants to receive either video dot or clinic-based DOT. So the patients actually had to go back to the clinic to be seen taking their medication. And what we wanted to know was whether or not treatment completion would be higher among patients in the video dot arm compared to the in-person arm. And I'll skip through these other two aims for the sake of time. And so this was a parallel randomized controlled trial. Patients had to be eligible for 3HP. We would enroll people 13 years of age or older. They had to be a resident of San Diego and not be moving in the next 4 months. They had to be able to use video dot, and they couldn't be in a court-ordered alcohol or drug treatment program. We enrolled participants from the 7 county Health and Human Service Agency regional TB clinics and UCSD Student Health Services and San Ysidro Health Center, which is a federally qualified health center. And the outcome was completion of treatment, taking all 12 doses within 16 weeks. And this is a very busy chart, but what this shows is that it was difficult to enroll. We had 1,900 patients who were eligible or who were diagnosed with LTBI, latent TB infection. About 70% of those actually showed up at the clinic to be prescribed treatment. Of those, 50% were eligible for the study for various reasons. The main reason was many patients were not eligible for 3HP or didn't want 3HP. And the main reason that people didn't want 3HP was they didn't want to have to go back to the clinic every week to take their medications. They would rather just take 4 months of daily rifampin at home. But we ultimately randomized 131 patients into the trial, half into video dot and half into DOT. And we followed them to see if they had completed treatment. So this just shows that we had equal characteristics in both arms of the trial. And here are our results. We ended up with treatment completion in 73% of the patients in the video dot arm and almost 69% in the DOT arm. So, and there was no difference between those two arms as we were expecting. When we looked at preference for treatment, we found that if patients had to redo their treatment, 92% of the patients in the video dot arm said they would want to do video dot, but and only 1% said they would want to switch back to DOT. But in the DOT arm, 50% of those patients said they would rather use video dot if they could, and only 28% said that they would use DOT again if they had to repeat the treatment that they just received. And interestingly, even though patients on the DOT arm didn't get to use video dot, 16% of them said that they would recommend video dot to other patients. So ultimately, we think that the reason that there was so little difference was because by the time we had selected down to the people that were willing to be randomized to either arm, basically they were going to take their treatment regardless. So then the question comes up, well, if you get the same results between video dot and dot, is there any other reason why you would use video dot besides patient satisfaction? And cost is a big issue. And from the study that I just showed you, we did a cost analysis, and this bottom line here shows you that 3 months worth of video dot would cost about $240 versus $318 per patient if they used in-person DOT. And then from that London study, we can see that video dot actually costs about 1/3 of the cost of in-person dot, and that's using the video dot for 7 days a week compared to 3 or 5 days per week of treatment with in-person DOT. And then in our first video dot study in San Diego, the blue line is the cost of DOT, the red line is the cost of video dot. And this is in San Diego and in Tijuana, and you can see a big difference in the cost between the two.
Richard, I just want you to be aware it's 9 o'clock.
Oh, geez, I'm sorry. Okay.
I know I was going to interrupt you, but there's been so much good stuff. So I don't know if you want to wrap up and we can see if there's a question.
Thanks, Jill. All right.
Yeah.
So just to show one last slide on the benefits, this study was done in Fresno, and they actually calculated that by using VideoDot for 62 patients, the county reduced their emissions and saved 41 metric tons of CO2. So this is good for the environment too. And then I will just wrap up by saying all these technologies can be useful for seeing whether a patient takes their medication, and that data could be put into databases, and that data can be made available to physicians, dot workers, case managers, health workers, etc., for lots of uses. But unless that information is used to help the patient, then we really aren't going to get the benefits of improving adherence. We're only going to be monitoring it. So my plea is that if anybody's using these technologies, it's to make sure that we're actually working with the patients to help use this information to help patients to take the medications. And with that, I'll take questions. Sorry about going over.
Oh, you're totally fine. There was so much good stuff there. The chat was quiet, and I want to open it up. Oh, there we go. I can look for you unless you can see it as well, from Daniel Park.
Okay.
Yeah. Is there any data looking at if meth use or other substance use impacts VDOT adherence?
Yeah, that's a great question. I think it's important. We didn't have a lot of substance use using participants in our studies in our sites. We did ask the question, and it was usually just about 10% were using drugs. But in the London study, they had quite a bit more substance use. These were really hard to treat patients, and I believe meth use was included there. And they had similar results. But Dan, I think that's a great question, and that would be a good population to look at. Thoughts on VideoDot application for opioid use disorder? Absolutely. I didn't mention it, but we were involved with a trial in Vermont with a substance use treatment program that's been ongoing for a few years now. And what they were doing was, instead of having patients come into the methadone clinic to receive methadone or buprenorphine and watch them in the waiting room taking their medications and sitting there for 10 or 15 minutes, the patients can take home doses and then record themselves using VideoDot. And they've found that to be very successful, and they're continuing to use it in their program. And so, excuse me, more research with that should be done, especially with COVID, because from what I understand, drug treatment programs have been sort of forced to give patients take-homes even before they would normally have been allowed that for the treatment. So I think this would be a great complement to opioid use disorder treatment. How's it going with use of SureAdhere globally? Is it being taken up on multiple sites?
I'll read just that to everyone. How is it going with the use of SureAdhere globally? Is it now being taken up in multiple settings?
Yeah, well, I'll say that VideoDot as a technology is being widely used around the world in multiple ways. SureAdhere has actually licensed its VideoDot application to another group that's based in India to combine the VideoDot technology with 99 dots technology and pillbox technology, so that a health department can be given one platform to choose whichever one of the three technologies they want to use, as a way to make it easier for low and middle income countries to adopt this technology without having to work with three different vendors or pick the one technology that they want to use. And this was done at the behest of the Stop TB partnership, and with collaboration with others in the global environment, to make this technology more easily and readily available. And that's scaling right now, and Unitaid is actually funding a 5-country trial right now to see how that works. So things are going well for VideoDot globally.
All right, I'm gonna call it. I mean, I think if people want to, this was great. I think if people want to email Dr. Garfein separately or, continue the conversation, you absolutely should. This was so informative and comprehensive. And I think something on the clinical side of things, we look forward to seeing, implemented soon. And maybe we'll hear about that next. And yes, we all agree to echo what what Dr. Dice has said. Great talk and speedy recovery. We hope you feel better soon.
Thank you very much.
Thanks so much, Richard.
Bye-bye.
Have a great weekend, everybody.